I have been taking care of children with epidermolysis bullosa and providing anesthesia care for them for many years. And it's an area that I'm passionate about and one area that has really brought me a tremendous amount of personal and professional satisfaction as I've had the opportunity and the privilege to take care of children with EB for many years. And it's really been fun for me to watch them kind of grow up from preschoolers to school-age children and some even into the college years. I have been inspired by taking care of patients with EB and their families. I have learned a lot from families, from my surgical colleagues, from my own experience. And what I'd like to do today is share with you a little bit about some perspectives that I hope will be helpful to you as you consider what to look for and what you might experience as your child with EB undergoes a surgical procedure that requires anesthesia. I know that anesthesia, even for patients who don't have any illnesses, is something that sometimes causes some anxiety and some worry. Is everything going to go okay? What's it going to feel like? How will I feel when I wake up? So what I'd like to do today is to help you better understand anesthesia for yourself or your child with EB, to know how you can help your anesthesiologist, to provide you with a few important questions to ask about the anesthetic. I know many of you are cared for in EB centers and a place where you're familiar, but you may find yourself on occasion in a place that you're not familiar, and the caregivers may not be familiar with EB. And I want to give you some tips for what to do in that situation, and also to give you a few thoughts about how to evaluate the quality of care that you're receiving. So, as we know, this is a rare disease. Blister formation is the hallmark. And that there's abnormal architecture of the skin, as has been so nicely pointed out on many fronts this morning. From an anesthesiologist's perspective, I look at things in a simple way of three major types, the most superficial being the epidermolysis bullosa simplex, often the least challenging of the patient groups that we take care of. Junctional EB can be certainly more involved, and dystrophic epidermolysis bullosa, probably the group of patients with EB that provide us with the greatest challenge. The dystrophic patients who have recessive dystrophic epidermolysis bullosa often have oral and esophageal involvement, the syndactyly that Dr. Stern spoke about, and this is the most incapacitating and disfiguring form, and also the form of epidermolysis bullosa that is most commonly going to require a surgical procedure. So what I'd like to do is to outline for you briefly what I'm thinking about as an anesthesiologist from the pre-anesthetic evaluation all the way to pain management after the procedure, and we'll look at these one by one. In the pre-anesthetic evaluation, it's very important to think about what related diseases are present. One of them was anemia that was discussed nicely this morning. I asked myself, are these diseases in the best possible condition before anesthesia, or is there something we can do to make them better? As Dr. Bruckner mentioned this morning, if there's severe anemia, a transfusion may be indicated to improve that before undertaking an operative procedure. An anesthesiologist is also thinking about other coexisting diseases that go along with epidermolysis bullosa. We're not just concerned about the skin, but other organ systems that may be affected. Starting with the lungs, patients with EB may have some decreased pulmonary functions, may have some more frequent respiratory infections, and may be at higher risk for aspiration. Musculoskeletal considerations, I think for the anesthesiologist, the thing that is of biggest concern and challenge is difficult IV access, and that we want to be sure that the patient is positioned and padded well for the procedure to avoid other injury. Patients who have recessive dystrophic EB often have esophageal scarring, and the esophagus does not contract normally. So that makes them more likely to have a condition called aspiration, where secretions from the esophagus that pool there could potentially go in the lungs and cause pneumonia. and that's one thing we pay special attention to. The anemia was already discussed. Other metabolic disorders that may be seen with EB are deficiencies of iron, zinc, vitamins, and selenium. Nutritional status could be poor because of oral intake and these esophageal strictures. And there's also, from the rapid turnover of skin and the scarring and the healing process, an increased demand for calories. That can all add up to result in some growth failure. Eye problems that the anesthesiologist focuses on are the presence of corneal ulcers, which are more common, and sometimes eyelid scarring occurs, which makes closure of the eyelid difficult. That's an issue under anesthesia because when you're under anesthesia, you produce fewer tears and you're at higher risk for corneal ulcers. So one other important group of information that an anesthesiologist needs to know about is your child's previous experience with anesthesia. And this is where you can be a real help, especially if you're going to a new center that hasn't taken care of you or your child before. So we're going to ask, how did it go? Were there any problems encountered? And as parents, I know that you guys are really tuned into and very aware of the health experience and what's going on with your kids. And one question in particular that's important to know about is how the airway was managed during the anesthetic. Was a breathing tube put in? Did they use some other approach to managing the airway and the breathing during the anesthetic? And in particular, you might ask at the end of an anesthetic, if they put in a breathing tube, were there any difficulties in putting the breathing tube in? Previous difficulties can help us predict how difficult that will be for future anesthetics. So that's one piece of information as a parent that you can really help your anesthesiologist with. I'd like to show you a few pictures of the airway and what we're thinking about as anesthesiologists. With EB, the mouth opening in the vertical dimension can be decreased, and the mouth opening horizontally can also be decreased because of scarring of the skin of the mouth. Because of poor oral intake and a propensity for easy-to-chew foods that may be rich in carbohydrates, dental problems can arise, such as dental decay. And one other thing that we see is what we call ankyloglossia, which simply means that the tongue over time can become fused to the floor of the mouth. So when I ask a teenager with EB to stick out his or her tongue, it really doesn't move very much. And that makes it a little bit more challenging for us to manage the airway. In addition, with the breakdown of the skin of the face, we want to be very careful so we don't have further skin breakdown. Patients with recessive dystrophic EB can certainly develop heart problems. The cardiomyopathy was mentioned briefly this morning, and that is thought to be related to carnitine or selenium deficiency. And basically what this is a heart that does not pump as strongly as a normal heart would, and it tends to become enlarged. For that reason, routine screening echocardiograms are recommended for patients with recessive dystrophic EB. And at Cincinnati, we do those on a yearly basis. That will allow us to predict and helpfully prevent heart problems during the course of the operation. Before surgery, we'll often obtain a complete blood count to check for anemia, and we might also check a renal and a metabolic profile to look at the overall health of the patient. What are some common surgical procedures that patients with EB will undergo? Dental rehabilitation is common, esophageal dilatation for strictures, and plastic surgery to correct the pseudosyndactyly, possible placement of a gastrostomy tube. Some other procedures less common are central line placement, dressing changes with whirlpool treatments, upper endoscopy, and then skin biopsies and excision of skin cancer. Some general principles that the anesthesiologist keeps in mind can be well summarized with this little label, handle with care, fragile. That is really one of our overriding principles, that we just want to be very gentle so we don't cause further skin injury. We don't lift patients, we don't slide patients, we lift them. We often will put them on an egg crate mattress from the beginning of the procedure when they first come in the hospital until they're in the recovery room. We will absolutely avoid any adhesives, adhesive tape, adhesive EKG leads, or the little pulse ox probes that measure oxygen concentration in your blood. And whenever possible, we leave patient dressings in place. They're there for a reason to protect the skin, and unless we need access to that part of the body, we will typically just leave that dressing intact. We have a little box that has all the supplies we need. We want to pad patients really well. You can see that the dressings are left in place, and that we also have a forced air warming blanket that we put over the patient to help maintain body temperature during the operation. We use silicone non-adherent dressings. There's many kinds available. The thing that we use that has been really helpful for us in terms of securing breathing tubes and intravenous catheters is the Mepitac, which is a 1-inch tape that we can really use in a way that we would use to tape an IV in for a patient where we can use regular tape. All right, so let's talk about what we actually do to get you or your child to sleep for an anesthetic for a surgical or a diagnostic procedure. Patients who come for repeated procedures, which can happen with esophageal dilatation or dental rehab, often after a while say, you know what, I know this trick, I've been here before and I don't like it. And they get anxious and not real happy about things. So in that situation, we will often give some sedative medication. It's an oral liquid medication that we can give by mouth or by gastrostomy tube. We can also give it intravenously. It's like a short-acting Valium medicine. It's used in adult anesthesia for outpatient surgery, many things. It's really nice. It just takes away the worries and puts the child in a much more calm state of mind. There's two basic ways that we can start the anesthetic. One would be to have the child breathe anesthesia gas through a mask. It's totally painless. It takes a couple minutes. It smells a little bit strong. Sometimes kids object for that reason. Alternately, if it looks like the vein will be easy to get, we might put an intravenous catheter in first and then give medication through the IV for the patient to fall asleep. In some hospitals, you may be able to be with your child for the start of the anesthetic. That may be very reassuring to your child and provide them with comfort. Once the patient is asleep, we're going to put a mask on their face, and we want to be sure that we protect the face. There's two ways we can do that. We can put some Aquaphor on the face, on the mask, and on the anesthesiologist's glove. Or we can use a foam silicone non-adherent dressing that acts as a buffer between our hand and the mask and the patient's skin. Once we start the anesthetic, we need to monitor vital signs through the anesthesia. We're going to monitor the EKG, the electrical rhythm of the heart. And what we've done here is we've cut away the adhesive portion. So there's just a little gel center of the EKG lead, and that isn't going to cause any skin damage, and we can just secure that with a non-adhesive tape. We're going to use this little device called a pulse oximeter, that little red light that you might have recalled if your child was in a medical setting, that measures the heartbeat and measures the amount of oxygen in their blood. And that's really important. It's a standard part of anesthesia care. And we don't want to use the adhesive Band-Aid style probe because that would cause skin damage, so we can use a little clip. There's also a new product out that is a Velcro wrap that is also very nice for EB patients. And lastly, we're going to use a blood pressure cuff over some gauze to help protect the skin. We're going to get an IV. Again, we have some padding under the tourniquet. We place the IV and secure it with some non-adhesive Mepitac, and we wrap it with gauze and secure it in place so that it doesn't fall out. That's really important because when you don't use an adhesive dressing, IVs are a little more likely to fall out. An IV during your surgery or your anesthetic is really your lifeline, so we want to be sure that's functioning well. What about eye care? Eye care is very important, as I mentioned before. And I would encourage that if your child or you are coming for a surgical procedure, that you bring whatever eye care drops you find work best for you. We tend to use a clear compound called Refresh. I think it's important to avoid anything with preservatives in it, with lanolin in it, or a petroleum-based product, because those can cause eye irritation. Intubation is the process of inserting a breathing tube into the airway. That is not necessary for all anesthetics and all operations, but it may often be necessary. And because of the changes in the airway, the scarring of the mouth, the scarring of the tongue, that can be sometimes difficult. This first picture here shows a standard laryngoscope, which is a rigid little metal device that we use to move the tongue out of the way so that we can see the opening to the windpipe and easily place a breathing tube in there. As EB patients grow older, they get progressive scarring of their mouth, and they get more scarring inside their mouth and in the upper airway. Tomorrow you're going to hear a very nice talk from an ENT perspective on one of my colleagues, Dr. Elleroux, on airway considerations for EB patients. Regardless of which technique we use, we want to be sure our equipment is well lubricated, and we may need a special device called a fiber optic bronchoscope to help us put in the breathing tube more easily. Regardless of how careful we are, I think you should expect some new lesions in the mouth of your child. As careful as we are, that often will occur. So here's a picture of what it looks like once the breathing tube is in. We use this cotton tie to help secure the breathing tube instead of tape. The eyes are closed and protected, and some foam is placed to avoid any skin damage. Dental rehabilitation is a common procedure. We tend to put the breathing tube in the nostril there, so we give the dentist all the room they can use to work in the mouth without a breathing tube in the way. Sometimes we don't need to use a breathing tube. We can use a less invasive device called a laryngeal mask airway, and that is basically a soft silicone mask on the end of a tube, and this goes inside the mouth and provides us with a safe airway. Sometimes we don't even need that. We can just use a mask on the outside of the face for a shorter case. Sometimes the patient doesn't need even a mask. They can just use a little nasal cannula, those little prongs, that we give some extra oxygen to, and they're breathing with their own natural airway. And we might use that, for example, for patients undergoing whirlpool treatments. Let's talk about some important medications that are part of every anesthetic, especially for EB patients. Pain can be a big issue, and narcotics are often used to provide surgical relief of surgical pain. If your child is taking narcotics preoperatively, they may need higher doses of narcotics to provide effective pain relief. One thing that's relatively new that we're starting to use is intravenous Tylenol. The Tylenol that you've known and used for years is now available as an intravenous form, and we found that to be a very helpful addition to narcotics and allow us to give better pain relief. Sometimes we'll give some non-steroidal anti-inflammatories in an intravenous form, drugs similar to Aleve, ibuprofen, that kind of drug. We'll often give some medication to help prevent postoperative nausea and vomiting. And after esophageal dilatation or procedures involving the airway, we will often give doses of steroids intraoperatively, most commonly dexamethasone. Regional anesthesia can be used. Regional anesthesia is basically numbing up part of the body where the operation is happening, and the brain is still awake. We might give some sedative medication. The difficulty with that theoretically is a risk for infection because the skin integrity is not normal, and we're putting a needle through there or a catheter through there to deliver numbing medicine on an ongoing basis. But this can be very helpful, especially for hand procedures. You can see here, this is a patient, this is the arm, this is the chest, and there's a small catheter here that is around a nerve sheath that's in the armpit that provides sensation to the whole arm. So that can give good anesthesia for the operation as well as afterwards. So a few closing thoughts addressed specifically to you as parents for how you can help when your child comes for anesthesia. I know it's going to be a time of worry, anxiety for you, not just about the anesthetic, but also about the operation. How will things go? What will my child experience? So I think if you control what you can control and give us good information, that will make you feel like you're in a better place and will certainly help your anesthesiologist. So bring your supplies. You know what works. You know what your child likes. We should continue that. I would encourage you, especially if you're going to a different institution from where you're normally cared for, is to bring the latest lab results that you have, any echocardiogram results about heart function, relevant medications, and medical records. Let us know what works and what doesn't work. And in my experience with EB patients, I rarely have to tell families to speak up because generally you are really good advocates for your kids, you care deeply about them, and that information can really help us meet your needs and the needs of your child more effectively. So keep doing that. I would also ask that you remind your anesthesiologist of details that sometimes we might overlook. Eye care, hey, where's the best site for an IV? The foot never works, the hand is usually good. And also to let us know about what your previous anesthetic experiences have been and what has been good and what hasn't been good. I believe that most anesthesiologists taking care of EB kids really want things to go well for your child, and we want to learn from previous experiences. So please help us and bring to us any information that you think would be helpful. So here are some questions you might want to ask your anesthesiologist. You might want to ask them about what is your experience with epidermolysis bullosa. You might want to ask for an anesthesia consultation ahead of time, especially if you're going to a new institution and they don't know you and don't know your child. The advantage to that is that it provides you at your leisure to talk about your child's medical problems, what the plans are, and just to get a good common understanding and build a relationship of trust with your anesthesiologist. That works much better than trying to do all those things in a brief time right before your child is supposed to go to the operating room. I would ask, what is your plan for my child? Are there any alternate plans? If plan A doesn't work, what's plan B? And what difficulties can we reasonably expect? I think those are good questions. If I were a parent, I would want to know those questions. So what should you do if you're in an emergency situation? You're away from your zone of comfort, your home base, and you want to be sure that your child gets good care. Be sure that the anesthesiologist is prepared and informed. And I want to tell you, for many anesthesiologists who are not familiar with EB, and I think this is true for pediatricians, for other physicians also, EB can be something that really makes us a little tense and a little worried. So, two resources that might be helpful to you. If you go to the DebRA website, there's a link there to the DebRA nurse educator, and you can communicate with Jerry either by phone or by email, and she can help facilitate sometimes physician-to-physician communication. So I get calls from time to time about a physician in another state who is taking care of an EB patient, and they just want a few suggestions or have a few questions. So I can consult with them by phone and I think really make a difference in how things go for that child. This is an excellent review article that was written a few years ago by one of my colleagues, also authored by our own Dr. Lucky, Dr. Aziz Khan, in Pediatric Anesthesia, which is a really nice overview of issues that the anesthesiologist needs to consider. So that might be even something that you think about having with you. How do you evaluate the quality of care that you're getting? I think with a rare disease like EB, experience means a lot. You want to go to a place that will do something frequently, where people are familiar whenever possible. Look for competence, look for protocols, but I think it's really important to look at the heart. do these people really care about me and my child? Remember, it's not just about a surgeon. It's not just about an anesthesiologist. It's really a whole team of people that provide good care. Do I feel listened to? And do I feel like communication is open and clear? Those are questions that you might want to ask as you look for places for your child to have an operation and an anesthetic. So, with good preoperative evaluation, with a high level of skill, with good judgment, patients with EB can have a very safe anesthetic. You won't feel better until you have your child back in your arms, but you can be sure that based on the technology and the drugs and the knowledge that we have today, that patients with EB generally have a very safe anesthetic course, even when they can be very sick. So it's been a real pleasure for me to share these insights with you. I think we have a few minutes left, so if there's any questions, I would be happy to take them. Yes?
Is there an alternative versus, my child has had a reaction to it, so it's listed as a reaction versus allergy?
Yes, we can use some narcotics sometimes. We can give oral ketamine. What was the nature of the reaction?
I don't even know. We got him when he was 9 months old, and it happened before we got him. So
Right.
I don't even know what. They just listed it as that.
That's the question was, my child has a quote-unquote allergy to Versed. I think sometimes it's worth figuring out what that reaction was, because sometimes a normal side effect is attributed to an allergic reaction. And generally with Versed, one thing that we see in older children is an opposite reaction. Instead of calming them down, sometimes it makes them hyper.
And I have another question. As far as the echocardiogram, my son has a chronic chest wound, and so they won't do it. I mean, is there something, an alternative to that?
There really is not a great alternative. Cardiac MRI imaging can be used, but I would think that they might consider placing some kind of barrier there and still being able to do the echo. Yes?
If you have a child who's going to undergo multiple procedures, what is your advice, generally speaking, for the duration in which you would keep a child under anesthesia? Meaning, a child may have teeth cleaning, multiple things, just because you're only so much, you'd like to do as much as possible, but at the same time, I imagine you only want to keep someone sedated for so long. So how do you balance those?
That's a great question. Just to repeat the question so everybody can hear, is it better to do like a lot of short procedures separately or to do all of them at once? I think the biggest risk is starting and finishing the anesthetic. Generally, the duration of the anesthesia does not increase risk. So if you get started and things are going smoothly, I would say go for it and do as much as you reasonably can, as long as your surgeons agree that those procedures are all compatible, if you will, rather than trying to break them up. So no risk in longer anesthetics as opposed to shorter anesthesia. Thanks very much. I'll be around. If you have other questions, feel free to ask.